Good morning and welcome, Dr. Dar. We are looking forward to your session on ABA and thank you, Neil, for doing this with us in collaboration. And I'll hand it over to Dr. Dar so we can make best use of our time.
There we go. Thanks everyone for having me come. It's always a delight to talk about behavior analysis, and particularly when it comes to making behavior analytics services more available to individuals who may greatly benefit from it. As just a very brief introduction of myself, my name is Jacob Daar. I am a associate professor at the Northern Michigan University. I'm also the director of the Behavior Education Assessment and Research Center, which is our university's clinic and ABA training facility. My background is fairly broad in behavior analysis. I've worked with very young children. I've worked with adults, both in the intellectual and developmental disability domains, as well as acquired uh, developmental or acquired disabilities, including traumatic brain injury and so on. Today, I'm going to be talking about behavior analysis in a very specific to the areas of autism and developmental disabilities, but I just kind of wanted to kind of briefly state that ABA is the applied extension of behavior analysis, which is really a systematic approach to understanding behavior and its relationship to the environment. ABA itself uses learning theory to essentially solve socially relevant problems. And while we're going to focus on autism and developmental disabilities, I just wanted to point out that clinical behavior analysis and applied behavior analysis is actually used in quite a broad arena outside of specifically developmental disabilities, but it's very relevant to behavioral medicine. It's very relevant to education, organization, and so on. So if you have any interest areas in those areas, I think it's worth looking into. But what ABA really is a very objective, very natural science way of understanding behavior. In the areas of autism and developmental disabilities, ABA has been around for a long time. And while it almost has somewhat of a buzzword kind of nature now, uh, the dominant psychology of the early 20th century was actually very behavioral. And the transition away from behavioral psychology is sometimes thought of as this thing that like it became a behavior analysis became passe, and that's not really true. It just was because it was always very much associated with developmental disabilities, much unfortunately like the lives of people with disabilities, it kind of went under the radar, particularly compared to kind of psychotherapy and talk therapies. But ABA has been used for the last 60 years, specifically to help individuals with difficult to manage behaviors and learning disabilities to develop more adaptive behavior. Particularly as applied to autism, it is considered an evidence-based best practice. It's one of the few evidence-based best practices. Very, very much so when you get into the significant impairments. So more of that like level 2, level 3 autism. So the more significant the impairment, the much more likely you're going to need applied behavior analysis. As a quick word on who provides ABA, in the last, really about the last 20 years in the United States and abroad, there's been a shift for behavior analysis to be its own discipline within psychology. The reason for that is because of the high degree of specificity in that training. As we'll talk about, behavior analysis in practice looks very, very different than most psychologists are trained to do. In the United States, we have the Behavior Analyst Certification Board, which is our primary credentialing agency. Almost every state in the United States or has licensure for behavior analysts that is separate from other disciplines. And the basic requirement, as we'll go over in a second, comes from the BACB. Internationally, the two organizations that provide credentialing are the International Behavior Analyst Organization and the Qualified Applied Behavior Analyst credentialing organization. Both of them operate internationally, and I know that IBAO does have resources um, that appear to be used in India. So that's I think that they might be a good one to start looking for. But generally speaking, we have a pyramidal model of supervision, not unlike in the medical field. Behavior analysts, BCBAs, IBAs, or QABA, those are the three different names under those credentialing organizations, are the kind of the bulwark of behavior analysis. They're master's level clinicians who have been trained to work independently. They sometimes have an assistant level, which we'll talk about as a bachelor's degree, but most of the direct work is done by paraprofessionals. In the US, we call them registered behavior technicians, so RBTs, and then there's various the other acronyms there. Um, to help you understand what the requirements are for these, uh, the BCBA is the one that's normally the one we're talking about. That's who practices independently. It's master's degree is required, 270 to 315 hours of ABA specific coursework, and this is where you see that separation from the master's level clinicians, is that that's an entire master's degree. That's basically all ABA classes, and then, excuse me, and then you take stats. And and that's very different than what a counseling or clinical master's level clinical psychologist might be trained in. And so that's why we have this different credential. It is also not uncommon for APA psychologists to specialize in behavior analysis. The 25th division of APA is the behavior analysis division. Those are the only two credentials that are typically going to be associated with behavior analysis, even though there are some other disciplines such as social work, speech language pathology. They'll sometimes get this additional training. We'll see where those overlaps are. The majority of the work, however, in terms of directly working with clients, is going to actually be done by technicians or paraprofessionals on a one-on-one basis. In the US, we require 40 to 50 hours of training. They have to pass practical and examinations that are provided by the behavior analyst and pass standardized exams that are delivered via the accrediting bodies. So we actually put a lot of training and effort into our paraprofessionals. And I think that's one of the things that makes ABA a little different. And as we'll talk about, it's very procedurally driven. So it's not the same as having somebody work in a classroom who has no training in how to work with people with disabilities. This is most RBTs are career RBTs. So behavior analysis has become increasingly in demand in the United States in the around the middle of the 2010s is when the insurance mandates started. So it became the most common complaint for mental health equity was rejections of ABA services, which all health plans have to provide now in the United States for individuals with autism, and as well as within Medicaid. So you can see that this is an area that's just increasingly in demand. To give you context, in the US and Canada, there are only 65,000 behavior analysts. So there's almost twice as many jobs. These are jobs that are being advertised. So there's as many jobs being advertised as there are behavior analysts. The demand for this service is obviously speaks for its utility. Okay. When we talk about ABA, we define the field by several dimensions. I'm going to move through these quickly because I want to spend more time talking about what actual treatment looks like. But the first three are not going to be surprising. The first is that what we do must be applied, meaning it has to be addressing socially significant behaviors. I don't treat stereotypy that is harmless. I don't work to reduce behaviors that are not relevant to the individual, that have no context on their life. And so as we'll talk about, we try to make a point of only targeting the most significant clinical features. When we talk about things being behavioral, what we mean is that it must address observable, objectively defined behaviors, as well as we'll see through the presentation. I don't spend a lot of time doing norm uh, uh, developmental norm referencing assessments, it's fairly irrelevant to most of our clients. Unfortunately, they're in that less than 2%. What I'm working on is the actual symptoms that they are experiencing. It's analytics, so it's very data driven. We use systematic and experimental in the sense of condition manipulation methodologies to determine if a treatment is effective, what the function of a behavior might be. Everything we do is always data driven. We are conceptually systematic, meaning that the way we conceptualize cases is going to be based very much within behavior principle. We're always going to be talking about reinforcement, stimulus control, as I'll review in a moment. Our methods are going to be based in the behavioral literature. And one of the, I think, most valuable things about ABA is that we are technological. And what I mean by that is that what our procedures are going to be explicitly described. It's not vague. It is uh, um, any procedure we give, there is a full write-up on how to do it, when to do it, who is delivering that procedure, how to respond. And the benefit of that is that it's very replicable, and it helps it to generalize across settings for the individual. What we do must be effective, meaning that outcomes must be measurable and significant. And so we place a lot of emphasis on single subject research designs because I'm not trying to reduce someone's anxiety by a measure of subjective points. I'm trying to help them access a world that they don't have access to otherwise. And so we're really looking for robust change procedures rather than something that kind of mildly might affect the person. And then whatever we do really should be affecting the individual in the natural environment, meaning our treatment should have sustainable, maintained effects that go beyond the clinic space or the room that we're working with them. They should actually change this individual's lives. So real quick, I'm going to give you a Psych 100 refresher, but it's important to understand when I'm talking about something being conceptually systematic, what it means. The way that we remain technologically proficient and conceptually systematic is that at its core, we are talking about learning processes, and we are focusing on behavior. When we talk about behavior, and I'm going to pick on our medical folks here for a moment, when you're coming from an allopathic background, there is a tendency to reduce behavior to a physiological experience. And while I think that is in incredibly important part of what is happening for the individual. The behaviors themselves are not just what's happening inside them, but also how that response system is interacting with a world and their learning system. So what this gains for us is when we are looking at behaviors as an act of the entire organism, it allows us to make sure that we are taking that person into account in terms of their environment because they're ultimately responding to a situation. The when we The other part of this is it allows us to talk about behaviors which are objective. We all have a different experience and a way of describing what we're feeling, but if you look at the DSM is largely a description of behaviors. The benefit of focusing on the behaviors is that we can agree that we're seeing the same thing. I sometimes will joke that if I one of the things that we're often seeing treatment for children with autism is for agitation. Well, I used to work in a high intensity clinic for traumatic brain injury, where what my children in the clinic doesn't even register to me as aggression and agitation. They're frustrated. It's very different looking. And so but ultimately we need to be able to agree on what behaviors we're looking at. The other thing is that we need to be able to agree that the environment around that behavior is important. We don't act in a vacuum. We're responding to stimuli. How we respond to stimuli is probably equally influenced by what's going on physiologically with us, but also with the history of interacting with that environment. The environment, therefore, is the thing that we can change the most easy. In fact, I think this is why ABA and the medical field make such for a happy marriage. Is the medical practices are often attempting to change the internal environment, where behavior analysts are very focused on the external environment. And because when we can combine both of those treatments, I think we have a better chance at helping the individual. But ultimately, I can change the external environment very easily, and it's very easy to ignore this part of the environment, as we'll talk about, especially for the caretakers who are in that environment too. Um, Ultimately, here we're talking about operant behavior conditioning and behavior change. And so, what this approach really allows us to do is we're going to step out of thinking about the behavior um, in a stereotypic way, but rather thinking about it in a functional way. What does that behavior do for that individual? Under what context does it occur? How does it change that environment? And so we have this tendency of focusing on the relationship between the response and the stimulus changes in the environment, focusing on function, not topography. And there are some topography components to when I'm working with a child, let's just say, who hits in the front of their head versus the back of their head. It helps me to understand maybe why they're doing it, but it's ultimately the why. Hitting in the back of the head is often sensory. We're hitting on into the kind of occipital bones, but hitting in the front of the head is loud. This makes a lot of sound, and that really affects other people around them. So the topography matters to an extent, but ultimately it's in service of understanding why that behavior is occurring, how it changes the environment. So again, just as a quick refresher, reinforcement is just a description of the change in behavior following changes in the environment. When a behavior occurs and it changes the environment in some way that leads to that behavior occurring more, that's reinforcement. And that's what I'm always after. I'm seeking how a change in the environment changes that behavior. Generally speaking, as you'll see with our behavior change procedures, I'm really always trying to train and support the development of an adaptive behavior to replace that problem behavior that maybe is causing issues. And so reinforcement is very important, but reinforcement is equally important for difficult to manage behavior. The behavior is a tool; it's happening for a reason, and and that reason is how it changes that environment. So that's what we're usually looking for. Um, Now, here's where the analysis part comes in. By looking at how behaviors occur, the pattern in which they occur in relation to changes in the environment, particularly things that might be a reinforcer, tells us a lot about why they are occurring the way they are. Very typically speaking, difficult to manage behaviors are going to be occurring because of variable schedules of reinforcement, meaning they don't always produce a change in the environment. It's essentially creating a slot machine. So every time the child engages in a meltdown or a tantrum, every time they engage in self-injurious behavior, it's creating or their behavior doesn't always get them what they want. Right. And so I can watch the pattern of behavior and take guesses about where reinforcement are coming and then set about doing a more systematic assessment. But understanding this helps to understand how we need to change situations. As I was just describing, very often it's counterintuitive, but I will tell the parent every time they hit themselves in the head, I want you to go over to them and give them attention. And that's counterintuitive, but I need to get the behavior back onto a schedule that can be modified. When schedules are on variable reinforcement, they're very hard to alter. So just being able to look at the way the behavior is occurring within a framework of reinforcement is helpful. Also, we know that schedule-induced behavior occurs. What we have here in this graph is a FR4 means fixed ratio 4. So every 4 times the behavior occurs, reinforcement's provided. Well, we know that in certain circumstances, the more frequently the behavior is reinforced, the more behavior you're going to get. And we call that enriching a schedule. So we can do that to manipulate the frequency of a behavior, whether it is a behavior we're trying to increase or decrease. But we also know that we can systematically thin schedules if we do it in a certain pattern. So I can actually increase the amount of behavior that's occurring. So here, this would be trying to create an adaptive behavior. I might have it on an FR1 schedule. So every time the child engages engages in it, I provide reinforcement, and then I slowly start to provide that behavior less free or reinforcement less frequently. So by an FR3, the child is now looking for a certain level of reinforcement, a certain consistency of reinforcement, but they have to engage in 3 times the behavior, then 5 times the amount of behavior. And that's how we would work out a reinforcement schedule until they don't need it anymore. Uh, but we also know, and this is usually the case of where behavior treatment plans fall apart, is ratio strain happens. And so if you change the frequency of behavior too dramatically, behavior drops off and you can't produce this kind of procedural increase. So again, we're still in a hypothetical context here, but when it comes to the application of these, this is what I mean by analytic, is I'm looking at data, I'm looking at response to intervention in a very, very concrete and systematic way. We also use extinction quite a bit, and extinction is simply when we minimize or take away the source of reinforcement. And we know, for example, that one of the characteristics of that is that there's going to be a huge increase in frequency or intensity of behavior when you take that away. This is usually where behavior treatment plans fail. You tell a parent, hey, when your child is engaging in that tantrum, you need to wait it out. You need to wait for them to be calm and then begin giving them attention again. That child encounters that environment and you see this extinction burst of behavior. Even though we know it's going to go away soon, that parent isn't going to be able to ride that wave. They're going to give in. And now we have variable reinforcement at a higher level of intensity. So again, kind of just understanding this basic framework of how to watch behavior and analyze it within this single subject research methodology or an N of one kind of approach. Differential reinforcement we use quite a bit as well. And this is the knowing that if you have 2 behaviors that produce the same reinforcer, they're very sensitive to when the other one is going to be reinforced. This is the basis of almost every behavior support plan for problematic behaviors. We're going to decrease and minimize reinforcement for an inappropriate behavior while attempting to either maximize or make more efficient the appropriate behavior. This is why problem behavior occurs, by the way. Hitting the child next to you is a much more efficient and effective way to get attention than sitting at your desk and waiting. If I don't want you to take away my toy, I can bite myself. But if I ask you, please, it doesn't always pay off. And so just understanding this contrast effect between behaviors. And then the second to last principle is discriminative stimulus control. So this is the idea that we're sensitive to the environment that happens before behaviors and specifically learning to read the signs of when reinforcement is going to be provided. That's ultimately what questions are. That's ultimately what tells us when to engage in a behavior or not. And we know that when you present the stimulus that behavior has been reinforced in the presence of in the past, behavior is likely to occur. If you create a context that is easily to perceive and that reinforcement is never or very minimally provided in, we know that that will drive behavior down. And so we use these kinds of changes in the environment to essentially signal to the child when this behavior is going to pay off or not. Because a lot of problem behaviors are not problems in and of themselves, they're problems of when they occur. I'm working with a number of young men right now. I say young, meaning 10 years old, who are beginning to engage in behavior that is very inappropriate in the moment at a clinic, but we have to help them recognize when to engage in kind of self-exploration, we'll say. There's an appropriate time and there's a not an appropriate time. And so that ultimately is what we're trying to target. And the last one, last principle before we dive into more practical issues are setting events and motivating operations. This is essentially the context, and this is where medication really fits into the understanding, is understanding that when an individual is affected by medication, really what we're probably talking about is a change in how reinforcement occurs for them. Are they sensitive to food or not at that time? You know, is their behavior appetitive or not is going to depend on medication. Many of the side effects of our medication is simply increasing or decreasing appetite, changing the way that someone sleeps or not. And all of these things affect behavior. But it's what it really, from a technological standpoint, it changes how reinforcement is received, how strong that reinforcement is or not. So taking all of these things into consideration, this is essentially what I just described, is that there are precursor antecedent events, whether it is setting events, so something like medication or fatigue or hunger. And then there's more specific motivating operations that have to do with when and why a reinforcer might be more likely to produce behavior or not. In those contexts, there are antecedent events that are signals for the behavior to be that the behavior will be reinforced or not. The behavior then occurs, it produces a change in that environment. And if that change happens to be reinforcing, that behavior is more likely to occur in that context in the future and is more likely to maintain in the absence of that reinforcement. So we call that our four-term contingency. That's the conceptual systematic framework we're going to be working under. So let's talk about the actual applied technological, effective, and generalizable part of ABA. In the United States, ABA in actual insurance lingo and health plan lingo is adaptive behavior treatment. Uh, and part of that is because the focus on it is to teach adaptive behaviors. Adaptive behavior deficits are part of many DSM criteria, but very specifically intellectual and developmental disabilities, neurocognitive disorders, autism. They are one of the core deficits of these disorders, and that's at the part that we're actually teaching. This is a much younger picture of me when I still have hair. So that's why I keep it. Promoting adaptive behavior is done in a very wide variety of arenas for behavior analysis. The one that we're most often going to be talking about is something called comprehensive behavior interventions, which we'll get to in a moment. But very, very long history here and quite a bit of evidence to suggest that this is an effective approach. The study here on the right is a randomized control trial study that was comparing ABA to eclectic approaches, which is really a euphemism and nice way of saying people just chose what they were trying to treat the kids with, which is very commonly the case. And so you can see that ABA is kind of associated with gains across domains, particularly strong in communication. And as we'll talk about, that's a major focus of behavior analysis because of its relationship to problem behavior. Problem behavior is usually a communication difficulty. But also in terms of improving ADL, so activities of daily living, academic skills, social skills. We're really a teaching profession. We're teaching how skills. We're creating reinforcement structures around skills. We do this through a number of mechanisms. Shaping, task analysis, and chaining are kind of how do we teach a specific skill. The shaping is really systematic reinforcement of a successive approximations, which is when we're not able to prompt or help them, give them a very specific way of prompting them through those skills, we can kind of just provide reinforcement in a very organized procedural way to increase that behavior by reinforcing the better version of that behavior every time, while simultaneously putting previous versions on extinction. Task analysis and chaining, this is where we develop essentially a breakdown of the skill of a complex skill into component skills. And then we connect each of those skills specifically by organizing them such that the outcome of the first skill is the antecedent to the next skill. And so I do this a lot with kids. This example on the right is from the literature by Stokes. They were teaching toileting behaviors. And so what I'll do with a child is I'll start off by saying like, okay, go potty. And that's the first SD. And I teach then that child to engage on, say, sitting on the toilet appropriately, and reinforcements provided for successively more independent versions of that behavior. And once they've mastered that behavior, then I will no longer reinforce that first part of the chain. And now I'll reinforce the appropriately cleaning themselves afterwards. And so we kind of systematically move through a more complex skill. The value of that is you don't accidentally miss a part. And so this is applied to getting dressed in the morning, making food, getting ready for school, going to school, riding in a car. So that we kind of use this procedure fairly ubiquitously. Promoting language and verbal behavior is probably what most behavior analysts do in the United States. Now, this is where they focus, in part because it's a lot of fun to work with kids and teach language, but also because of its impact. If you start with a very young child, 3, 4 years old, who is displaying deficits in language, you can make a lot of ground and reduce a lot of problem behavior that may occur later on, as well as helping their quality of life. There's entire journals devoted to this, so I won't spend a ton of time on it. But know that the way that we do it is through very structured teaching procedures. We identify what targets we want, and that is the exact kinds of responses that we want the child to be able to respond to. So the exact stimuli we're going to present, exactly what responses are. And then we provide reinforcement for every trial and prompting for every trial that's necessary. And this is very effective, particularly for children with autism who need a lot of direct contingency learning. Where they have difficulty generalizing. We also do a lot of this in natural environment or incidental environments. So we create play opportunities. The children in my clinic spend about 50% of their time in a playroom playing with their technician. The technician is just trained to implement language learning opportunities within a game and play-like environment. This is a shameless plug for one of my pieces of research, but it is just to point out that we teach more complex language as well. Even though a lot of the focus is obviously on early kind of requesting and communicating wants and needs. This study, I worked with children to teach them what we call pragmatic verbal analysis, or answering questions through inference. This was community helpers. So who do you see at the hospital? If a doctor makes you feel better, where do you go to feel better? Those kinds of questions. And so we can teach more generalized emergent repertoires of behavior by carefully constructing the information that the child receives, and by focusing on generalized skills as a target. So once the child has begun to acquire more, we might call them simple or elementary language operants, such as just requesting or labeling, we then start to move into more of these kind of what we call derived relational responses, or kind of responding to emergent properties of language. So putting together the pieces of language to have a more complex response. This also gets into social skills. So we teach perspective taking through this methodology, emotional responses, and various other things. Now, I want to make sure we spend a little bit of time here on reducing problem behavior. This is one of the main things behavior analysts do. We reduce problem behaviors through functional behavior assessment and function-based behavior support planning. You'll also hear that called sometimes positive behavior support planning, though I like to emphasize the function-based part, because the positive component is often thought of as just being nice. And really what we're saying is teach them to do a thing that replaces the problem behavior. But you need to know what the function of the problem behavior is in order to do that. So a functional behavior assessment is an approach to behavior assessment that focuses on identifying objectively defining behaviors and then measuring those behaviors in objective terms and the environment in objective terms. So I spend very little time using, Likert type scales and subjective scales, subjective interviews from the parents. I do a lot of direct observation and manipulation of context during observation to see what's actually affecting that behavior. Really what I'm looking for is what variables in the environment influence the behavior, what variables in the environment can I change to influence behavior, and then testing those to make sure that they actually change behavior in accordance with the hypothesis that I have. There's no point in giving a parent a behavior support plan that isn't going to work even when I'm controlling it. We then develop a function-based behavior support plan, which utilizes that information to create strategies for reducing the problem behavior by modifying those motivating operations. Sometimes that just means medication. Very often it means medication and changes to the environment that help to reduce the need for that problem behavior. We then teach we have methods for teaching and promoting alternative behaviors that produce equivalent types of reinforcement, or if not equivalent, ones that actually compete, as well as develop strategies for the caretakers to engage in when the behavior occurs, so that they don't get in that cycle of variable reinforcement. So what does that look like? When determining function, I'm asking, when is that behavior likely to happen? With whom is it likely to happen? Where does the behavior occur? Is it a particular place? What other things are happening? As an example, sometimes the behavior only occurs when they haven't had their meds. That's an easy solution, but it's often missed. I can't tell you how often that is the case when I'm working with children with ADHD, and they just medications with much quicker half-lives. You just sometimes don't unless you're asking those questions, you just don't see it. I look at topography because it helps me to understand if that behavior is efficient, if problem behaviors tend to be very efficient. And I'm often looking at the alternative behaviors. If you're saying, why doesn't the child just ask for the toy? I want to know how often that actually works. I want to know, what do they have to do to get your attention? One of those behaviors is more efficient. It's usually the problem behavior. Um, I might look at who they target. I have individuals in my clinic who only target small staff members with aggression, because those are the staff members who are susceptible or vulnerable to that behavior, and because they change the environment, where most of the kids don't engage in that kind of high intensity aggression towards me anymore because it just doesn't work towards me. So I look at how can I change and train staff to respond better to problem behaviors, and more importantly, how to respond more efficiently and effectively to appropriate behaviors. So this helps us develop a functional hypothesis, which is really just a statement of what variables are in place, the behavior is likely to occur because in the past, what was that consequence? So, as an example, when attention is being provided to another child, Jacob's likely to engage in screaming and self-injury because in the past, the adults respond to that behavior by providing reprimands and they might be using physical management, which is physical attention. So it tells me that I need to start using attention from adults to help promote a different behavior. And I need to be looking at the context under which that adult is not coming back to that child. And so there are kind of common functions. You might hear me say escape or access. I'm just referring to these kind of in a categorical term. In practice, I'm very specific about it's when dad responds in this way, when mom responds in this way, when the teacher responds in this way. So the form part is not forgetting why. Now, here's one of the most important reasons why we approach it this way, is that appealing to function allows us to avoid circular logic. Why did he hit? Well, he was frustrated. Well, how do you know he was frustrated? Because he hit. And I'm gonna look at you, Neil, because you and I talk about this a lot. I cannot stand the term agitation. Agitation is a behavioral symptom. It's not why they did something. We can tell that they're exuding behavior because a context is not in a way that the child can navigate. They don't have the behavior to navigate it more effectively. And so by focusing on the function, it allows us to actually alter something that we've seen to be robust here. I'm going to fly through things because we're running out of time. I will stick around longer than uh, 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 15 minutes ahead of time just because I can run to my meeting. They'll be okay without me. Typical behavior change strategies that we alter timing of events and schedules. We look at the physical environment and modify that. We alter the availability of items. Sometimes that's just making them more accessible. Sometimes it's making them less accessible. We address those motivational variables. I'm going to talk about medication management and why ABA is so valuable to pediatricians in a moment, but we decrease the difficulty of the alternative and appropriate behavior while increasing the difficulty and response effort of target behaviors. I'll make that behavior take 20 times longer to pay off if I can, as long as I can make the alternative behavior pay off more quickly. We'll teach new skills to replace inappropriate skills, and we provide reinforcement for that alternative behavior that might not be effective, and which is usually the case. We'll also minimize reinforcement for the problem behavior. So in practice, here's just some examples from the literature. When we're doing an assessment, on the top here, we have something called a functional analysis procedure or experimental functional analysis. What that is I will literally take that child and put them in different contexts that focus on different forms of reinforcement. In this case, attention is usually I'll have them in the clinic and I'll say, all right, you go hang out by yourself. I've got to work. I'm going to sit here and I'm only going to respond to that child if they hit themselves. I'm going to come over and say, oh, don't hit yourself. We don't do that. We got to be nice to ourselves. And then I'll go sit again. And what I'm looking for is, does that child use that behavior to bring me to them? As opposed to escape, where the child can come sit with me and we're going to do work and I will only leave them alone if they hit themselves. So I will systematically do this in a very intentional way. And if the behavior is occurring, it means that behavior is being reinforced and it's relevant to the context under which that behavior is occurring. On the bottom there, you have a different procedure. It's called a functional preference assessment. This is a kind of similar version, but instead, I'm just saying to the kid, hey, what do you want to do? I'm over here with the toys, or you can sit by yourself. And we will see where the child allocates their time, even if they can't respond verbally to that. I just look where they spend their time, knowing that you're likely to prefer what you want and what you want the environment to look like. And you're going to move away from the things you don't want. So the child who wants attention is going to come to me. The child who wants to be left alone and doesn't want to do work is never going to come to me when I'm giving work. So I can do this, but it's very systematic. And that's the important part. We're demonstrating the function, not assuming it. Here's an extension of this into treatment. So you can see on this first part of the graph on the left, this is where we're doing that functional analysis procedure. This is from Wacker 1990. It's a good example of the process by which behavior analysts work through an intervention. The treatment package here includes functional communication training, which is teaching the child to request a particular outcome through some kind of man. Sometimes it's just hitting a button or raising their hand, but very often we're teaching them how to ask for it. This is also looking at prompting. You see their aggression is the behavior they're targeting, and signing is the man. That's the requesting for what they want. And you can see one of the benefits of the way that we approach this is we systematically demonstrate that this treatment is effective. And then, assuming that there's restrictive parts of this procedure or parts that are hard to maintain over time, we have the methodology to continually kind of titrate the treatment to determine whether or not all parts of that treatment component are necessary, because sometimes they can be very intensive and require somebody to work with you all the time. Our goal is to generalize and reduce that treatment to the point where the child no longer needs it. We're aiming for least restrictive, most effective. Here are some more examples. Again, these are all function-based treatments. A DRO procedure is one in which we provide reinforcement of a particular kind on a time-based schedule when the child doesn't engage in that behavior. NCR is non-contingent reinforcement. This is one of my favorite stories of most effective treatment I have ever done. It was my first case. The child engaged in hundreds of instances of self-injury per hour. He just hit his head all day long. And I determined that this is how he got attention. All I did was ask the teacher to every 2 minutes go over to this child, put your hand on their shoulder, and tell them good job. That's it. And very quickly, I was able to spread that out to 3 minutes, 4 minutes, 10 minutes, and eventually this child was walking around doing schoolwork and asking, "Did I do a good job?" And was no longer hitting himself in the head anymore. And this is a child whose hand was like calcified into a club. So it can be incredibly effective. And all that it took was actually no one in that classroom would have said that this child was attention maintained, that behavior was dependent on attention, but it was through this kind of very careful observation. This example on the right by Vollmer is a good example of, again, that titrating out the treatment. We fade it. And so you'll recognize that from that schedule-induced behavior that I was talking about. We have ways of slowly moving that treatment out, so it isn't always happening, which is usually what we do, is moving clinic implementation into a home implementation. So I like that you were talking about the development of a clinic and whether it's going to be inpatient or kind of daily treatment environment, because for kids who are more significant and severe needs, you really do need to be able to have that control. You can't walk into someone's home environment and make those changes and expect that they're going to be maintained. Comprehensive behavior interventions is just a description when we put that function-based intervention in with the adaptive behavior training. In the US, that really just means 15 hours or more of treatment. I have kids that are with me 30 plus hours a week. They basically come to school with me. We do all of the things I talked about, as well as parent training and development towards parent implemented interventions. This is I think the most preferred and most evidence-based approach. So if you are thinking about doing this in the best possible way, I would be looking into comprehensive behavior interventions, or sometimes you see it referred to as early intensive behavior interventions, EIBI. Now, very quickly, because I know we're running out of time, other applications of ABA into pediatric and behavioral medicine that I think are very important to recognize is, first, how valuable ABA can be towards medication management. We are almost to a fault notorious data takers. And if you are giving medication for agitation, sleep issues, um, withdrawnness, those are very subjective concepts, but I measure them. And so very often I can show you if we have good communication, and more importantly, if I'm working with you. Neil and I have been talking for a while about developing protocols for helping behavior analysts to and parents to better measure behavior for the purposes of medication management. And side note, Neil, I think this is what my LEN trainee is going to be doing this year, is that I am looking at not just whether or not the child engages in aggression or self-injury or meltdowns. I'm also looking at how fast they're learning. And one of the things we know, particularly around the antipsychotic medications, risperidone in particular, I have a fight with it, is that it may reduce agitation, but now this is a child who's not learning. And I would rather have a child that's a little feisty and difficult to manage in my clinic who's also learning, because that's how I'm going to ultimately be able to reduce the reliance on the medication. So very, very useful in looking at behavioral correlates to medication use. We also are really good at decreasing medically significant behaviors, things that you don't necessarily think of as behaviors that clearly have some medical component to them, also have a behavioral component. I've done a lot of work with individuals who ruminate, looking at how can I effectively give them access to stimulation if that's what they're doing it for. Or just simply, I worked with a child and figured out that they just were eating two breakfasts every day, one from their school, one from home. They were both milk and cereal. All I had to do was change this child to make sure that he had at least one peanut butter sandwich. Then he'd get bananas at school, and now he's not ruminating. I've also worked with an individual who would ruminate because it kept people away from him. He didn't have to do any work all day because no one wanted to touch him. Um, because he would vomit onto his desk and then they'd have to clean it up. And so I just kept working with him. I just wipe it to the side and keep working. And very quickly he stopped engaging that behavior. And this is a highly destructive medical condition, you know. Bruxism and teeth grinding, we have half of our kids come in with teeth grinding. And all we have to do sometimes is just have a very specific prompting method to say, hey, stop it. We'll just rub their cheek. Sometimes it's providing ice every so often, and they'll use that as an alternative sensory reinforcer, or we have a alternative reinforcement structure where they get access to a particular reinforcer for not engaging in teeth grinding. And now they're not grinding their teeth. Just some other examples: food refusal and overselectivity is often looked at as a stimulation issue. It's very often a behavioral issue that's coming from usually children who've had feeding issues early in life. I've worked with a lot of children who had various issues with GERD or were on feeding tubes, failure to thrive issues. And then because of that, they've developed aversion to many foods. And I will point out, the only time I do this therapy is when a medical professional has said this child doesn't have a swallowing issue. This child doesn't have a digestive issue. Usually this is a child who's eating chips and French fries and chicken nuggets, or only drinking uh, uh, formula milk of some form. And so what we do with that child is develop a reinforcement sequence of: you do the behavior, you eat this thing that you like, we go play. You eat this thing that you like, we go play. You eat this thing you like, you go play. Now you eat this thing that you sometimes like and we go play. Now you do that 5 or 10 times, and eventually we can get them to eat things that they've never eaten because they know what's going to happen. They know, I eat this thing, I go play. I eat this thing, I'm going to go play. And so lots of research and practice in this area of helping children, particularly children with autism, who have become somewhat stuck in their ability to eat new foods because behaviorally that kind of meltdown tantrum self-injury behavior kind of comes out very quickly. Sleep difficulties, very often sleep difficulties are associated with the problems of non-cooperation with sleep are happening because the individual just simply is engaging in other behaviors that disrupt sleep in order to get other reinforcers. This could be as easy as make sure they have all the things they want before they go to bed, as well as teaching the parents you just can't respond sometimes at night. When they get out of bed, you just take them back to bed, and then you got to leave them in bed. And then looking at this again in conjunction with medications can be very helpful. Again, we are obsessive data takers. And we often have this data, even if you don't know it. Helping them prepare for medical procedures, teaching them to sit, in this particular study was teaching medical professionals how to deliver what we call high P sequencing, which is behavioral momentum. It's give them two easy things that have nothing to do with the medical exam, then give them the medical exam question. You want a child to open their mouth and stick out their tongue? Tell them to touch their nose, touch their head, then stick out their tongue. It just helps a lot because of it. You get them essentially motivated for the social reinforcement, and then you take advantage of the fact that you've got them engaging in the behavior for it. And then some other versions of this is compliance with medical recommendations. Wearing medical devices is something we do, again, through reinforcement structures. And then medical compliance during very difficult medical examinations. And I'm thinking here dentistry is where I often will bring it up, because that's a really hard situation for people who are easily overly stimulated, who don't like bright lights, don't like being touched. And so I work with kids for at a very basic level of like helping them get their nails clipped, all the way up to how do you sit in a chair and have someone manipulate things in your mouth. And so helping them to tolerate that sensation, helping them to develop reinforcement structures that let them learn how to go through that process is really helpful. And again, I think about a lot of our kids who have feeding devices, medical devices that they can't take off, they need to wear, they can't remove. I'm thinking about children with IVs. So lots of other applications to medicine that you might just not think of because they're not autism specific. It's very, very helpful in that area. All right. I think I only blasted past my time a little bit. I'm happy to sit and answer any questions. I'm sure they can survive the council for 10 minutes without me. Is there anything else that I can answer, or any specific questions?
I have tons of questions, but this was just amazing. I think for me to learn this early morning. But I just had a couple of questions about parents. How do you involve parents in it? Like this is training the
Parents?
kid.
Yeah, so we have through so adaptive behavior treatment has a billing code for parent training. So depending on which one we're talking about, which goals we're talking about. So in terms of problem behavior, I often say it's like there's no point in teaching the child to behave at the clinic. That's not the point. The point is to help them navigate their world and their community, and that means teaching the parents how to act like behavior therapists. There's quite a bit of studies out there on teaching parents to implement behavior treatment. That's one of our main things, is to teach them how to basically be a behavior technician. One of it just starts with teaching them how to recognize function-based thinking, and getting them to recognize antecedents of behavior, how to get them to recognize the environment and then change the environment, as well as to implement the specific behavior support plan. We do that through behavioral skills training. So the same way we teach the kids, we teach the adults. And the other part of it is parents are very much involved in the process. We don't make goals for the child, the parents do. We try to make sure that the parents are very invested in that change. This is a therapy that takes sometimes 30 hours a week. We need the parents working alongside us. So I have parents come in on a weekly basis to participate in sessions. So if I'm working on language acquisition, we work on language in the clinic with the kids. Then we have the parents come in and work on running that language so they can then go in the home and prompt that child through using that language. So it really just depends, but best practice is parents need to be involved. Otherwise, it doesn't generalize as well, because in the same way I was showing you that graph that says like in context A you act this way and in context B you act this way. That's very true of their behavior. Even if it's the language and adaptive behavior, they might not use it in context B because it's never reinforced in context B. So you got to help the parent. If you want it to occur in the home, the school, and the community, you got to train the people in the home, the school, and the community to implement it.
So I'm sure that
Usually,
involves unlearning their old pattern and relearning the new pattern.
well, and it's recognizing that the parents are under their own contingencies of reinforcement. There's a wonderful article by Aaron, I think, Arryon, that looks at a functional analysis of parent behavior, of non-compliance with medical recommendations in parents. And what it's looking at is essentially when you give parents a treatment plan, they don't do it because it's effortful. It's not reinforcing. It can be very punishing. And the example I usually give of this is, and I'm sure you've all experienced this, is you give parents a recommendation, even you give clients a medical recommendation. They don't take the med because it doesn't feel good. Parents don't run behavior plans because they don't feel good. They're counterintuitive. They're annoying sometimes. They take a lot of effort. And if you have to survive an extinction burst, a parent's not going to do that. So you have to kind of be conscious of what you're asking them to do and how it affects them the same way. And so we have we do that as part of the functional behavior assessment, and we have a specific billing code. We're allowed to bill for parent training. That is, I think, one of the most important parts. Clearly part of our clinical guidance, the evidence-based practice manuals always include parent intervention. I will make one asterisk on that, which is that you cannot require parent intervention because that is an equity issue too. There are families where the parents are just not going to be successful partners, and you shouldn't deny a child access to services because their parents or the caretakers or the context they're in just isn't going to allow for that. So it's better if they are, but be mindful of the fact that if you can involve the parents, some treatment is still better than no treatment.
Good to know. Absolutely. Thank you. I'll hold off my other questions, but Anurag, if you want to wrap up, and any other comments.
I wanted to bring in Dr. Neil for a few minutes, just give him an open mic and what he would like to say.
Yeah, no worries. First of all, I'm very thankful to Jacob for doing this just before our meeting. And thankful to all the participants for being here. I think, Anurag, what would be a nice follow-up to this is, if you all have concrete next steps for Dr. Dar in terms of, what does it look like after you talk to your team? What does a partnership, a training, an arrangement look like? Because it only is worthwhile if this then translates into some concrete actions. The lecture is fantastic. It opens our eyes to a lot of things. But moving ahead with your vision would be like, what would it take next, right? Is this something that's a partnership with Dr. Dar and NMU? Is this a partnership with somebody else from, QABA or somebody else internationally? I think that will be, the next very important steps. If you all can convene as a team on your end, come up with some action steps, and then reach back out to him and we can see what is feasible, practical, and the timelines.
Very well. Very well.
I'm also very happy to have another, however many sessions of chatting about. This is obviously my favorite topic, so I'm more than happy to.
I was going to say you were as good as any investigator or a forensic scientist or something. I think it's just amazing. There's a method to the madness for the whole thing.
Let me bring in Dr. Sudarshan. Dr. Sudarshan, you wanted to say something?
Yeah, it was for us. It's an introduction. We can say that we are introduced to it now, and as Dr. Neil said, now we need to actualize this. So I think, sir, you and me have a task on hand.
Yes. We are going to do that. To do that. Dr. Neil has actually given me some pointers. And Dr. Neil, I'm going to Bombay on the 6th of January, and I'm going to meet up with people there and see what we can do to carry this forward. And definitely we have to come up with a concrete plan to take this forward so that we can get some training in, and over the next 5 or 10 years work towards setting up a center. That is the timeline that I'm looking at. The next 10 years to get a few people trained and get this thing rolling. That is what we are looking at. Anybody else, if they have a quick question, please unmute yourself and ask. Dr. Dar is about to go, and Dr. Neil also. They're both going to the same meeting. So anybody wants to ask anything, please do that.
Looks like no one wants to ask but me. But the last question I had before you we let you go is there regression? Are there like chances of regression when you're working with these kids and parents if it's not
Yeah.
followed a certain protocol?
Yeah, so as I was saying, much the way that behavior is shaped by the environment in a good way, if you allow the environment to return to what it previously was, you can get essentially regression. But it depends if you do it thoughtfully. This is why we focus on teaching adaptive behaviors rather than punishing problem behavior. I can get any behavior to stop very quickly by using aversive stimulation. I can provide punishment. I can use timeout. But once you remove the punishing context, the behavior will come back. And if you don't provide an alternative behavior that's more efficient and effective, the behavior is still the most effective tool. Why would you use a screwdriver when you got a power drill? And so we need to make the power drill not work in some way, or help the individual develop better skills, or no longer need to drill something in, if that makes any sense. And so I think generally, yes. Sometimes what we'll do is we'll do a withdrawal test where we will just take away the behavior treatment. And if the behavior comes back within hours, we didn't do a very good job. That treatment's not effective. Keeping in mind, some clients, they're the most severe clients you're going to have. I have a colleague who works with kids who eat their own hands. I mean, just absolutely mutilating themselves. You're never removing treatment. It's never going to happen. But you can move in a better direction. And my background is much more strongly in rehabilitation science than it is in what you might think of as like classical psychology background. I continually think about how do we move towards the least restrictive, most effective care for that child. And some children might require some intervention their whole life. That's going to be the case for many, many individuals. The goal should be to get them to the point where they are going to experience the best possible outcomes without regressing. Maybe that's remaining a certain amount of medication. Maybe that's remaining a certain amount of controlled environment. But ultimately, that is going to be the goal of treatment is driven by the caretakers, by the parents, or by the individual. And most of the time, there's a clear goal of we want the child in the home. We want the child to be happy as possible. And so we have to kind of balance those needs. So short version of that is yes, you can see a regression if you allow the environment to reinforce the problem behavior in the ways that it was before. And I'll always point out, like, when you go home to your parents, you start acting like a child again, because that's the context. That's what you've learned to do in that environment. And you have to go through a process of becoming an adult and teaching your parents to treat you like an adult. And so you have to slowly change those environments, if at all possible. My parents still don't treat me like an adult sometimes. So I think that's kind of how you have to think about it, if that makes any sense. But it is something we're
Absolutely.
sensitive to. We have a whole bunch of other strategies that I didn't talk about on how we generalize skills, introducing common stimuli, bringing in the parent. That's why we bring in the parents, so they can learn how to implement the skill. So the child learns that this skill works with the parent. We do it in their community, and then we'll slowly shape that behavior into something that's more manageable. There's a whole other area I didn't talk about of teaching tolerance behaviors, meaning teaching the child how to accept waiting and not need reinforcement to be provided in such intensity all the time and very quickly. And that's really one of the core problems of that individuals have. And so there's a really, really great set of literature by Greg Hanley on what's called skill-based training. If you're looking for, like, I need one procedural set for all problem behavior, that's where I would start, because it's very systematic. It very heavy focus on how do you get this to a point where it generalizes without, and this is for aggression, SIB, that sort of thing. Where if I had to give this to a technician who knew how to run it, I'm gonna focus on teaching this individual how to be calm and wait. Because a lot of times problem behaviors are just happening between hey, you did the thing, let me go get the thing that you want. And then the child doesn't understand that what they've asked for is coming. So, sometimes that entire area is another area of what we do to help generalize skills to make it more likely that the treatment's going to last.
Jacob, I'm going to jump on the council call whenever you can get there. That's great.
I do have to get running.
Yeah.
Sure.
All right.
Thank you so much. We'll definitely,
Thank you.
we can do another session for hands-on clinical cases and things like that. So thank you so much, Dr. Dar.
Yep, and my
thank
email's
you,
right
Neil.
there. Feel free to email me. I'm happy to continue chatting or set up other times to chat if that's helpful. I do have to run. I've got to run across town and it's snowing, so.
And be careful, please.
Thank you.
It's slippery out there. So thank you so much. Bye-bye.
Thank you.
Thank you,
Thank
Doctor.
you all.
Thank you very much.
Bye-bye. I'm going to close the session.